My name is Sydney Chahonyo. I am a cancer survivor. I'm also a cancer advocate, and I will be your session chair for the day. I'd like to welcome you all to the 2023-2024 Africa Cancer Research and Control ECHO program. A few housekeeping rules. Please be mindful of each other. If you're not speaking, kindly mute your microphone. We would also like to see all your faces. So if your bandwidth permits, we'd like you all to turn on your videos so that we can have a more interactive session. You can always feel free to introduce yourself in the chat, ask questions or make comments. Although we will have a huge session for question and answer and discussions later on. Your subtitles on your screen if needed, and the sessions are actually recorded, so I'm sure you will have access to them even after this. Now, today is the 21st of September, and we are in the 2023-2024 Africa Cancer Research and Control ECHO. What is the ECHO? The ECHO is a community of practice. It's a community of learning. It's a network that comes together to discuss the implementation of evidence-based initiatives and interventions to advance cancer control in the Africa region. This includes the identification of barriers, facilitators, and additional research that is needed to further advance the adoption and uptake of locally relevant interventions at the local, national, and regional level. Some of the topics we plan to cover in this year is prevention, diagnosis, staging and screening, treatment, palliative care and survivorship, service delivery, governance, health workforce, health information systems, research, and finance. And of course, this is all driven by the need in Africa and by suggestions from people within the region. What are our topic objectives for today? At the end of this session, we hope that everyone should be able to understand, number one, how to plan HPV vaccination rollout and target milestones for successful implementation. That includes policy engagement, government involvement, partner mobilization, and community buy-in. Secondly, we want to know how to ensure sustainability through anticipating the challenges and planning possible interventions. Basically, we're here to learn from each other. We're all at different stages in our HPV rollouts, and we want to hear from people who have walked the journey so that we can then use that experience to be able to do it in our own settings. The agenda for today, we are going to have a case presentation followed by a didactic presentation. Each speaker will have about 15 minutes to do their presentation. And then after that, we're going to have about 45 minutes of back and forth moderated discussion where you can ask your questions and weigh in and give your comments. So without further ado, because we are pressed on time, I'd like to introduce our first speaker today. Our first speaker is Dr. Simon Manga. He's a reproductive health specialist. He's the Deputy Director in charge of clinical affairs at the Cameroon Baptist Conventional Health Services. He's also adjunct faculty at the University of Alabama and Birmingham School of Medicine in the USA. Dr. Manga has been working in the field of cervical cancer prevention for over a decade. He led the first ever HPV vaccination project in Cameroon with donated Gardasil 4 from Axios Healthcare Development, where 6,800 girls aged 9 to 14 were vaccinated, and they achieved an 85% coverage with 3 doses per girl. So without further ado, I'm going to give the floor to Dr. Simon Manga. Feel free to share your slides. Over to you, Simon.
Thank you very much. Thank you for the introduction. I thought the slides were going to be shared for me from that end. So that's what I was told. So do I share from my end?
If you're able to, you can share because you have been given the rights to share. But okay. There you go.
No, it's already on the screen, so I think we'll just go ahead. Okay, thank you so much. Thanks for that introduction. So let's just move straight to the presentation. So I'll be presenting on the experience of Cameroon, particularly the Cameroon Baptist Convention Health Services, the organization where I work for. And we have enormous experience in HPV vaccination. So I'll be sharing my work or our work in Cameroon. So we'll be talking on, so this is an outline, very brief outline of the presentation. Next slide. So introduction. The Cameroon Baptist Convention Health Services is a large faith-based healthcare organization that has a network of 95 health facilities in Cameroon, and the CBCHS runs the most comprehensive cervical cancer prevention program in Cameroon. And the program is called the Women's Health Program. Since the year 2007, the program screens an average of 8,000 women for cervical cancer per year. And so far, we have screened over 120,000 women. I don't want to go into the details of how we do screening, because this is focused on, the presentation is focused on HPV vaccination. So we also have extensive experience in HPV vaccination. Next slide. So our experience in HPV vaccination can be divided into 3 phases. We have the first phase, which is the first HPV vaccination with Gardasil 4 demonstration project in Cameroon, which we conducted from the year 2010 to 2012. A second stage, no, I'm still there. The second stage is the implementation of HPV vaccination, Gardasil 2 in Cameroon. That was between 2017 to 2019. And the last stage is where we are now. We have collaboration with the National Expanded Program for Immunization in the country to administer Gardasil 4. We started that 2021 and we are ongoing. Next slide. So the first HPV vaccination project in Cameroon, this was a demonstration project which we conducted from 2010 to 2012. We received 19,200 doses of Gardasil 4 from Axios Healthcare Development to vaccinate 6,400 girls. So by this time, nothing was known in Cameroon about HPV vaccination. So we were the very first to introduce this. And in those days, they were given 3 doses. So the dose schedule was 0, 2 months, and 6 months. Next slide. We tried 3 approaches. We piloted 3 approaches during that demonstration project. One approach was a clinic-based approach, which we just offer the vaccination in the clinic, and then parents come with their daughters for vaccination. Then a school-based approach, we went to schools to vaccinate children in school. And then the last step was a mother-daughter approach. With a mother-daughter approach, we combined HPV vaccination with cervical cancer screening. So here we go to a community and we say, we have come for 2 things. We are vaccinating the children and we are screening their mothers. So the mothers come along with their daughters. And as you can see from these 3 approaches, the mother-daughter approach had the best results. So we succeeded more with the mother-daughter approach, though it had its own disadvantages. And the main disadvantages of the mother-daughter approach was to get back these girls with their 2nd and 3rd doses. Because to go back, it was difficult to regather the mothers the mother and the children again at 2 months and 6 months for the subsequent doses. Next slide. So overall, this is what we found. Overall, we have first dose, so we vaccinated 6,800 girls, and with second dose we achieved 95%, and third dose completion we attained 85%. Next slide. So we published this paper, Achieving High Uptake of Human Papilloma Virus Vaccine in Cameroon, Lessons Learned in Overcoming Challenges, which is the first ever HPV vaccination article in Cameroon. Thank you. Next slide. So in the middle of that, our demonstration project, we had a scandal. This is a newspaper scandal. Is one of the greatest challenges we went through. At the middle, the newspaper came and published this scandal. It's in French, Cameroon. Majority of Cameroon is in French. So they say Mama Fuda authorism vaccine kit too. Mama Fuda was the then Minister of Health. So here they are saying that Mama Fuda authorized a vaccine that kills. And if you go under, you see, I say, cell of Cameroon and Africa accept it's a vaccine. It's a vaccine. So they say only Cameroon in the whole of Africa has accepted this vaccine. And in the next point, they say, Plusieurs décès déjà enregistrés. That several deaths has already been registered. And to where the page where they were talking on the story in proper, they said corruption au sommet de l'État. Corruption at the head of the state. Mama Fuda authorism vaccine kit too. You know, we just did not just do the vaccination. As a faith-based organization, we involved the government. So we had the covering of the government. We had authorization. We have their blessings. We work together. And so that is why the minister was so involved in this. Okay, next slide. So this is the second phase, implementation of HPV vaccination, Sevarix 2 in Cameroon. Because after our project ended in 2012, people kept asking, they wanted a vaccine. And you know, it was a donation, so it was free of charge. And now we could not get another donation. So we went to buy Sevarix 2, and we administered it. So from 2017 to 2019, we administered Sevarix, but now it could not be free because we actually bought the vaccine. And this was for women 9 years to 55 years old. And the girls 9 to 14 years received 2 doses. That was a recommendation at the time, 6 months apart. While from 15 years and above, they received 3 doses at 0, 2 months, and 6 months. And the costs were given out just for partial cost recovery. We're giving a dose at $21. And the cost was so prohibitive that we started reducing the prices. The price was close to expiry. We had to give it as low as $10 per dose. Next slide. So this is what we attained in that project. For 1,447 women received the first dose, 1,226 second dose, 843 third dose. Next slide. So our major challenges with this second project was the cost. The cost was prohibitive. And over 15,000 doses of the Sevarix expired. And it did not even expire in Cameroon, it expired on transit, because we took the first consignment. We ordered for 100 doses, 100,000 doses. So we took the first 50,000 doses and we're not even able to administer it completely for 2 years. So we did not even bring the second consignment. It expired in transit. And then our organization lost over 100,000 US dollars for that project. That was quite discouraging. Next slide. So this is where we are, collaboration with the National API program on vaccination that has C4 from 2021 to date. So the EPI introduced HPV vaccination nationwide in September 2021 for girls 9 years old with 2 doses 6 months apart. That was a countrywide campaign, and they actually vaccinated in schools, mostly in schools and in health facilities. And there was a lot of vaccine hesitancy, probably because there was no proper sensitization. And it was at the same time when the COVID vaccine came up and people were suspecting that is a COVID vaccine that they are bringing it under a different name. So hundreds of thousands of doses started expiring in the warehouse. And then our organization then stepped in to assist the government. Since we already had that, the track record of successful vaccination and the trust from the people. So we stepped in to assist the government. Next slide. So we are currently using the following approaches. We do school-based approach. Now, the Cameroon Baptist Convention, the CBC, is a large organization. It's a church, it's a faith base. So we have our churches, we have our schools, we have our hospitals. So in a school-based approach, we have limited it just to our CBC schools. And then we are doing health facility clinic-based approach, which we have also limited to our hospitals. Then we do mother-daughter approach, which we take to the community. And then of interest, we introduce a church-based approach. So we are also vaccinating in churches. Next slide. So this is the result of what we are doing so far since 2021. The vaccination in churches is yielding the best results. Next slide. So from January 2023, the government approved single dose HPV vaccination and also approved vaccination of girls. Next slide. So from 2021 to now, this is what we have vaccinated, boys and girls, as you can see in the slide. Okay, next slide. Just some picture galleries. Next slide. Next slide. Next slide. Yeah, next. Thanks for your kind attention.
Thank you very much, Dr. Manga. It's interesting to see how things work differently in different situations. At the end of the day, we are always looking for African solutions to African problems. And we thank you for sharing your experience with us. I can see some questions coming in on the chat, but I'd like to leave those for the discussion, which we will have later on. Benda Kitaka, I can see your question. We will deal with it during the Q&A. So for now, I want to swiftly move on to a different country that has a completely different experience. And I want to introduce our next speaker. Our next speaker is Dr. Hassan Sibomana from Rwanda. He works at the Rwanda Biomedical Center in Kigali, Rwanda. Dr. Sibomana is the EPI manager for Rwanda. He is affiliated to Rwanda Biomedical Center, the implementing agency of the Ministry of Health. He holds a Master of Science in Epidemiology from the University of Rwanda and a specialized degree in Leadership and Management of Vaccination Programs as a result of field practice and training from the University of Global Health Equity in collaboration with the Yale Institute of Leadership and Management. He has extensive experience in maternal and child health and Rwanda's health system acquired through various occupied leadership positions in the last 10 years. These include being the head of maternal, child, and community health in Rwanda. He played a big role in new vaccines introduction in Rwanda, routine immunization, and ensuring the sustainability of achieved performance in the vaccination program. He led the process of developing a national deployment and vaccination plan for COVID-19 and coordinating the immunization operations for both routine immunizations and COVID-19. He's very passionate about ensuring access to vaccination services. And in his own words, no one should be left behind while eligible to any health service. So Dr. Sibomana, I'd like to welcome you to give the didactic, your own experience from Rwanda. Maybe we will see some similarities and some differences between what's happened in Rwanda and what's happening in Cameroon. So please take the floor, Dr. Sibomana. Over to you. Yes, we can see you, but I can't hear you. I think you're...
Sorry, can you hear me?
Yes, we can hear you now.
All right, so thank you. Thank you very much. So I'm very happy to join this forum. So I will wait slide to be projected. I was told that the projection will come from your side. Okay, all right. Yeah, thank you. Can you use presentation mode? All right. Yeah, thank you. So what I'm going to present is just the experience from Rwanda of HPV vaccination program. So which started in 2011. So far, I have vaccinated a very big number of girls, more than 1.5 million now. Next slide. Yes, so actually we talk a little bit on Rwanda EPA background, Rwanda and the global strategy to eliminate cervical cancer, decision-making and the plan of HPV vaccination rollouts, and also HPV vaccine delivery strategies for successful implementation. And then we shall see how we can sustain vaccination program, most especially HPV vaccination. Yeah, thank you. So as background of Rwanda EPI, so actually you can see on this slide, actually it is a summary of vaccination program in Rwanda. Since we started this vaccination program with very few vaccines, traditional vaccines today, but also you can see over the years we have been able to introduce new vaccines, starting in 2002, when we started to have the support from Gavi, with introduction of pentavalent vaccine containing hepatitis B and Haemophilus influenza. But also you can see that 2009 we have been able to introduce pneumococcal vaccine, HPV in 2011, rotavirus vaccine 2012, measles and rubella combined vaccine 2013, and also polio inactivated vaccine. And of course, recently we have been able to introduce a COVID-19 vaccine to vaccinate all our population. And also you can see that the achievement is very good, because since 2002 actually have been able to achieve a very good coverage for DPT3, more than 95%. And currently, if you look at HPV, so we have been able to vaccinate more than 1.5 million girls. And also you can see over the years, actually the vaccination coverage was 90% and above. And also you can see that for measles and rubella vaccine, so actually we are able to vaccinate more girls. So now in Rwanda, we are using 12 antigens in routine vaccination. But also if you look at the fully vaccinated children, now we are at 96%. Next slide. So now actually Rwanda joined the global strategy to eliminate cervical cancer. So actually, you know, we're focusing on prevention, early detection, but also treatment. So the objective is just to achieve 90% of vaccination coverage, diagnose at least 70%, but also treat at least 90% of those diagnosed positive. So, and then you can see only after 1 year after the introduction, so our vaccination coverage was very good, more than 90%. and also to ensure that we can easily eliminate cervical cancer. So the government is now piloting a screening and treatment program at a health center to catch lesions before they become cancerous. But actually today the coverage of these services, so we are at 93% of health facilities here in Rwanda. Next slide. So, and then for HPV vaccine introduction, focusing on decision making and also a very good plan to introduce HPV vaccine. So actually we started by a very big commitment from the Ministry of Health. And also we have been able to involve all the high leaders of the country. And we have been receiving also a very good support. So for example, in 2011, when we introduced HPV vaccine, so the guest of honor for the launching ceremony actually was the first lady of the country. So this is very important actually when you are starting a new program, because actually it helps for social mobilization, and also have been able also to use data which were available at that time. In 2011, actually we had very few data, but we have been able also to cross-check and try to understand what is the burden of cervical cancer here in Africa, most especially in East Africa. And we have seen that actually the burden was not very low, because actually 49% out of 100,000 women, so actually they were having cervical cancer. And also the big task was to advocate for vaccines, and also using the high leadership of the country. So we have been able to mobilize a number of doses, more than 600,000 doses, so donated by MSD MEC at that time. So actually that number of doses actually was to cover only 3 years, but also we had the chance of having a Gavi commitment to support HPV vaccine beyond the first 3 years of vaccines donated by MEC. And we have been able also to use data from Rwanda Cancer Registry. At that time, actually, it was only from teaching hospitals, because actually, if you look at other hospitals, actually, there was no data, because actually most of these cases were being transferred to teaching hospitals. But also have been able also to use global evidence for vaccine efficacy, but also for vaccine cost effectiveness, so that we can even convince people that it is needed to introduce this vaccine, but also to how they support and making sure that we can secure also line budget in the government budget, because, so we received a donation as vaccine doses, but ready to ensure that actually even administer this vaccine. So it was really a big challenge. So there was a need to mobilize funds from the Ministry of Finance. Next slide. Next slide, please.
Just give him a minute. I think there's a problem with the sharing.
Yes, thank you. So actually, to ensure that you're introducing a new vaccine, you have to make sure that also you have the space, you have the capacity to store the new vaccine. So at that time, actually, we had a chance, because actually you have seen how we have been introducing new vaccines. Actually, you have seen that in 2019, there was an introduction of Prevena, pneumococcal vaccine. So it was very easy also to use that opportunity, because actually the space was there. So meaning that at the introduction of HPV vaccine in 2011, so there was really no need to add more refrigerators in health facilities. So we used that existing storage capacity to ensure that also that facilities can host this new vaccine. So the strong point, actually, it was a collaboration, because, the HPV vaccine, it was a new vaccine to a new targeted group, but also have seen that it was a new vaccine to be used outside of health settings. So that is why really there was a very big collaboration with other government institutions, including Ministry of Education, but also our partners to support this initiative, and they try to help us to explain to our community that it is a needed vaccine and it is a very good vaccine, but also a safe vaccine. This is the most important one. Because at that time, actually, in Rwanda, there was a very big campaign also at that time to ensure that actually family planning also we can reduce the fertility rate. So we had issues actually around these two campaigns, because introducing HPV vaccine targeting only girls, so actually people confused this vaccine on the also family planning method, and it was very difficult to convince people. But we had a very good team, because at that time we had a social mobilization team, which was being led by the Minister of Health, because specifically for the Minister of Health, we have a division in charge of communication. So it is very important actually to ensure that you have a very good team, which can easily be in touch with the different stakeholders, but also try to help to explain what is happening, so that people can have all the trust that you can avoid that vaccine hesitancy. And then the decision for us, it was just to start the vaccine at national scale. We didn't plan to have a demonstration approach. And the initial decision was to start both primary prevention and the secondary prevention together, because at that time we had a very good support from MEC through MSD, and it was a donation for HPV vaccine, but also testing kits. And also from 2011, so we had actually a hope that this is a very good program which can be done very easily, because after the first year of implementation, we have seen that the coverage was very good, and we decided to push and make sure that actually this can be a very good program targeting these new girls, but also making sure that the coverage is kept high. Next slide. So it was very important to define very well what will be the strategy. And you have seen that actually we were targeting girls between 9 and 12 years. And actually that group age, actually it was a big number of them actually were in schools. So meaning that actually the strategy we chose at that time, actually it was just vaccinating girls in the schools. And let alone in 2014, after the commitment from Gavi of supporting HPV vaccination. So we have seen that actually we need to move from age group so that we can target one single age. Because actually this was also a recommendation from Gavi to ensure that we exactly plan very well number of doses. And then I have to say that out of school girls, so we have been using community health workers to ensure that actually we are having all of them and good enough. So the number was not big, because actually the enrollment at that time, it was 98%. All girls actually have been attending sport. So we have published a number of papers, like this one is actually an example of what we have published in 2020. So we actually have seen that more than 1.1 million girls were vaccinated with first dose. And from 2011 to 2018, actually the coverage was almost 98% of the eligible targets. So this is a published paper. You can find it online. But currently, as I have said, so we have seen that actually we vaccinated now more than 1.5 million girls. Next slide, please. So the implementation of HPV vaccination, actually, you can ensure the success when you are also monitoring what is happening, but also trying to see how you can engage the community, but also to hear a perspective of different stakeholders. And the first stakeholders, actually, they are beneficiaries. Adolescent perspectives actually are very important. And also the thought from teachers, parents, nurses, actually, who are much involved in this activity, but also community health workers. This is very important. And also partnership and collaboration. So you need to make sure that actually you are collaborating very well with partners and other government institutions, because we have seen that actually as Minister of Health, it is not enough to say that we are having a very new program like this one. So there is so many ministries which were involved, like Minister of Education, Minister of Gender and Family Promotion, and also Minister of Local Government, so that you can ensure that you can have also a very good support from the local leadership. Local authorities can support and also supporting in awareness to ensure that actually they are always communicating that there is a new program to the community. This is very important also to have a very strong interdepartmental collaboration, as I have said, with Minister of Education, strong coordination between the EPI units at the national level, district hospitals and health centers, teachers and community health workers, and also involvement of local leaders in the community, and a strong partnership and communication support from Rwanda Health Communication Center. So as I have said, this is a division in charge of communication, all communication from the Ministry of Health, actually channeled through this division. So it is very important actually to ensure that actually you are engaging all of them. Next slide. So this is what we have achieved since we started to introduce this vaccine. So you can see from 2011, so the vaccination coverage was very good, more than 90%. So the following year, and also the third year, and starting in 2014, actually vaccination coverage also it was 99. And you can see that in 2015 there was a drop in coverage, because at that time also we tried to see how we can integrate HPV vaccination in routine vaccination. So, you know, at the beginning, actually used to deliver this vaccine using campaigns mode. It was very, very expensive. So 3 doses, because at that time, actually the schedule was to give 3 doses at first contact 2 months later, and also at 6 months. So to fund actually to finance this activity was very expensive, because at the end we have seen that we have been using 1 million USD to cover 3 rounds of campaign. And when we started to integrate HPV vaccine in routine, so we have reduced these costs at 80%, because currently we are delivering at least 1 dose using 1 USD. And so you can understand that actually there was a very good improvement in terms of also reducing the amount we have been using. So you can see on this slide, actually have tried to divide it into 3 parts. So in the middle, actually it is when we started to have a support from Gavi. But before, you can see the 4 years before, actually it was donation. And the last part on your right, actually can see in red, it is where we started to have this issue of COVID. When we changed the strategy of administering this vaccine, so we switched from school-based approach to the community, because actually at that time there was a closure of schools. And we have been able to sustain at least the continuity of this service. But still, you can see that the coverage was very low. So it drops, because at that time there was a fear. So it was very difficult actually even to find the girls to go out from their home and make sure that you can vaccinate them in the community. And you can see in green in 2022, so actually have been able to see how we can revitalize HPV vaccination program. And now the vaccination coverage is still increasing. So we are now focusing on a HPV vaccination coverage to ensure that actually you can keep it at 90% and above. So you can see that actually there was so many scenarios, so in which actually can serve as lesson learned when there was campaigns, when it was integrated in routine, but also when there was a change in strategies, instead of using school-based approach to use also the community. Next slide. Yeah, and then for sustainability, so actually it is very important to integrate HPV vaccination program into routine vaccination, micro-planning. This is very important. And ensure that when they are planning for outreach vaccination sessions, also they are considering these outreach we are conducting in the schools. And also on our side, we are trying to see if it is really very important for us to switch from 2 doses to 1 dose. You know, there is that recommendation. And we have submitted our request to National Immunization Technical Advisory Group to see, to seek their advice and see if really it is needed to switch from 2 doses to 1 dose. So we are still waiting the decision from NITA, their advice. And then to ensure the sustainability can be possible. So also there is a need to ensure that people are owning this program, the ownership of health facilities and local leaders as other vaccines. This is very important, and they have to make sure that actually at least they are having this commitment to ensure that no one is left behind. And also there is a full involvement of leaders in charge of education, because definitely you have seen that actually one of the factors of the success for this HPV vaccination program is just a very good collaboration with Ministry of Education. And also we need to continue to increase the awareness of beneficiaries, because actually every year there is a new cohort to be vaccinated, meaning that actually need to give chances to our beneficiaries, so that today, if they have that information for next cohort, also we need to ensure that they will have the same information, so that we can benefit from actually their collaboration. And also we have seen that we need to build a very resilient vaccination program. We had a very bad experience from COVID pandemic, and also to make sure that actually when you are also changing the strategy you are using, you still have the room to continue delivering also and providing services. So in a brief, this is what I have been able to summarize, so that we can discuss on this, how also this HPV vaccination program can be improved, but also it can help us listen to other countries.
Yes.
Thank you.
Thank you, Dr. Sibomana. And thank you to both speakers. One problem, two very different approaches. I'm seeing over 1.5 million girls being vaccinated in Rwanda, whereas Cameroon is vaccinating both boys and girls. Some of the issues I've seen, supply chain issues with vaccinations expiring in transit, cultural and faith-based issues, the perception, the trust of the community, as a community trust the vaccine. Another thing, there are different approaches that were used, from community-based to clinical to school-based. Why change from one to another? Which one had the most success? And also just some of these are the questions people might have, like how to get buy-in from the stakeholders, the key decision makers and other stakeholders, all the way from the top of the ministry to the mother and child who need the vaccination. So I want to open it up to a question and answer session, and I want it to be more of a discussion. I see a couple of questions already on the chat. Starting with Benda. Benda asks, Dr. Simon, you have mentioned that the mother-daughter approach was most successful. What is your thought on the WHO guidelines on single-dose approach combined with the mother-daughter approach? Maybe you can take that one first, Dr. Simon.
Okay, thank you very much. That's an interesting question. Yeah, we in Cameroon, we started doing a single-dose vaccination beginning 2023. So it's something new that we are not yet, we have not experienced for a while. We don't have much experience in that. And since 2023, we have not conducted a mother-daughter approach. We are planning a huge one in 2024, where we'll see how it goes with the 1 dose. And we hope that we are going to get more uptake with the 1 dose strategy. Thank you.
Thank you. Another question from Mary Mwangi asks, thank you for the updates. You mentioned inclusive, or that your program was inclusive of boys. How do you include boys on the single dose approach?
It's just the same. It's the same. You just go, like we go to churches to vaccinate, to schools. We open the vaccination to both sexes. The parents who are willing that their children should be vaccinated, they sign a consent form and we go ahead to vaccinate. So it's the same vaccination schedule nothing changes.
All right. Now I actually want to open up the floor. And Benda Kithaka, you had a question about civil society actors. Maybe you can just unmute and ask your question.
Okay, so this question is to Hassan. You've talked about how Rwanda, through government engagement and through commitment from policy, has made sure that you continuously, even after COVID-19 recovery, you're continuously hitting the 80%, 90% mark. How do you engage with civil society organizations as well as other actors in civil society to ensure that remain engaged in the vaccination programs? Thank you.
Yeah, thank you. So this is a very good question. So we have seen that actually for this specific vaccine HPV, it was not easy for only Minister of Health to ensure that actually can have a very good success. It was a new vaccines, new age group to be used outside of health facilities. And actually there is that rumors related to fertility. So, you know, it was not easy. For us, what we did is just to ensure that actually we are communicating very well with all partners, including civil society organization. So the good example is the girl effect. So we had the chance of having girl effect here. And we took that advantage to use their magazine, which was distributed in the schools. And we secured the one page always for each version. There was a page dedicated to HPV so that we can communicate very well to adolescent girls. But still, we engaged other civil society organization, and also our awareness actually was very intense. So it was, we were very aggressive in communication to ensure that actually we are communicating very well that there is a new vaccines, and also having very good examples. So when there was a big meeting, actually we used also the opportunity of having survivors from cervical cancer. So to show to the community that actually it is real that cervical cancer are there, because, you know, it is somehow a disease which is not known, because actually it is somehow hidden because of cultures here in Africa, when people can be sick, but it is not easy actually to reveal that actually she's sick. So we use that opportunity also to ensure that actually the awareness can be very effective, because actually at that time it was very difficult to explain that we need these vaccines. It was a new vaccine, and actually, you know, Rwanda was almost the first country in 2011 to have this vaccine in routine immunization. So it was really very difficult, so that everyone should be involved. So there was a very good role from UN agencies, WHO, UNICEF, UNFPA, to explain that actually they are supporting this initiative. But also I have to say that we had a chance of using the experience of introduction of other new vaccines like pneumococcal vaccine, which was really showing a very good result on that side of pneumonia. So for us, we had that chance of having also the trust from our community, because actually, if we have a policy or something to be coming from the Ministry of Health, so we have a very good support from the community, because actually they have that trust. And also having the first lady at launching day. So it was very important also for us, because actually at that time everyone understood that really it is very important, because actually we have also that support. For civil society organization, it was also very important, because actually for us what they did is just to help us for awareness and sanitization. So this is very important. So this is what I can say.
Thank you very much. I see Edna Tembo had a question also. Maybe you can unmute yourself, just give a brief introduction, name, country, and then ask your question. Edna Tembo.
Yeah, greetings. I'm Edna Tembo from Malawi, working with Coalition of Women Living with HIV and AIDS. Sorry that I joined late. I had problems with the network. I wanted to understand how our colleagues worked around with communities to make sure that they accept girls to receive vaccines and reach that target. As in most of African countries, we have some beliefs around vaccination, and also with the effect of COVID, many people are reluctant to receive more vaccinations. So I just want to learn how our colleagues did how they managed to catch a lot of girls receiving vaccinations. Thank you, and over.
Thank you, Edna. I think Dr. Manga alluded to that in his presentation. Maybe you can start, then Dr. Sibomana, you can give your thoughts afterwards.
Oh, yes, thank you. Like I said, the key has been sensitization. You sensitize the people. The parents, you don't target the girls, you target with the parents. Let the parents understand, and then they will bring their children and give you the permission. Go ahead and vaccinate. You know, one of the errors that our government made that had a lot of challenges is that they just took the vaccine to schools and started vaccinating without even consulting the parents. And it created a lot of problems in the country. So to me, I would just say the key is sensitization. And if you see in church, where we have done huge amount of vaccination, it's because we use the clergy, the church leaders, the pastors. They are very influential. When they speak, people follow. So you go and sensitize those very influential people, and then you use them to sensitize, like you use the pastors to talk to their Christians. Or you go to a community, you get to the chief, sensitize the chief, and then get him to talk to his subject. When we do that, we see better results than if you were just to go straight on your own. Thank you.
Thank you, Dr. Manga. Dr. Sibomana, anything to add there?
Yeah, thank you, Chair. Thank you, Edna, for this important question. So it is true, actually, in our culture, it is not easy actually to convince people that this kind of vaccine are very important. And actually for us in Rwanda, we had a chance also of having access to umbrella of religious. So to talk to this umbrella, actually it was very important, because actually in that way, you can make sure that actually the communication is straightforward to their their people. So it's very important for us actually to mention that also have been using this umbrella. And also, as my colleague from Cameroon is saying, so it is also very important to make sure that actually we are investing a lot in awareness and sensitization, and ensure that actually we are using a very known people from for political leaders, from high leadership, because actually they are the one to support, also to communicate. When they are communicating very well, so it is successful, because actually when you're having this kind of support, it is easy for you to go back and try to explain. And it is true, for any new vaccine, actually there will be rumors. So this is the same cases to COVID vaccines, but we have been able to vaccinate now in Rwanda more than 90% of our population, because actually there was that support from the high leadership. And for us, actually, when you go down there, so the work is very easy, because actually you have at least other people who are supporting the initiative. Thank you.
Thank you. I see Eunice Wambua also had a question. Maybe you can unmute yourself. Just a brief introduction and ask your question.
Good afternoon, everybody. I'm Eunice Wambua, a breast cancer survivor from Kenya. I wanted to know, is the vaccine safe for people who are above the limit age of 14? And what is the maximum age that you can give the vaccine?
Caroline, please mute yourself. Thank you. I don't know if you got that, Dr. Manga and Dr. Sibomana. Any one of you can take up that
Yeah,
question.
thank you. So probably I can start. This is a very important question because currently we are also seeing a very high demand of adult women seeking the HPV vaccine. So what I have to say is that this vaccine is still expensive. We are focusing on adolescent girls, but it is a vaccine which can be given to even young women. But still, what is needed really, it is just to make sure that you screen first so that you can vaccinate. So it is very important to mention that there is not much evidence on effectiveness in adult people. But still, we are having now a project in Rwanda where we want also to vaccinate young women from 23 up to 30 years. And then at starting 30 years, actually, we will be, the priority will be screening. But still, it is something, it is a vaccine which can be given to adult people. But the effectiveness can't be as in young adolescent girls. So this is very important also to highlight, because actually the purpose here is just to make sure that you are vaccinating someone who is not yet exposed to these viruses. So, and then the screening, this is where need to focus for adult people, so that once you diagnose very early, you can also be able to treat. So this is what I can say. Thank you.
Can I just make an input as well? This is Daria Fideli. I'm a medical oncologist. So there is no issue with the safety based on age. So just to say it specifically that the vaccine is safe, even in older people. So there's no issue with safety. If someone already has HPV and they get the vaccine, it doesn't make them any worse. It's not doing the job because the person already has it, but there's no safety issue. In some other countries, when resources are not a problem, the age recommendations go much higher, and also in certain populations, depending on what the risk is. So there's no safety issue based on age.
Thank you, Dayo. Dr. Manga, you had wanted to add something?
No, I just wanted to say that here in Cameroon, we just limit the vaccine to the adolescents, and then we emphasize that the elderly women should do their screening. We do screening from the age of 25. You don't just think about the vaccine, just come and get your screening, regular screening, you will be fine. Thank you.
Thank you. Benda, before we get to you, there's a question from John Black Kabuke. John Black, are you with us?
Yes, I thought the question was clear, but what I needed to find out is whether there's been some studies to demonstrate the impact, the outcome, and I mentioned that it might be early to, see any effect on the really end goal, which is eliminating cervical cancer. The outcome would have been in incidence of cervical cancer, so it might be might take a while because this is a cancer that takes a while to evolve, but there might be some other things on the way, like pre-cancer lesions, especially from the Cameroon example, where older women were vaccinated. Do we have some evidence on this? Because I think that can encourage governments and donors, but also patients to vaccinate. So do we have some evidence from the presenters, but also from others on the call?
Thank you, John Black. Maybe we can have Benda weigh in on, give her input now as the doctors think about that response.
Now, can I speak to John Blacker's question?
Go ahead.
Yeah, this is Annette Nakaganda from Uganda Cancer Institute. Yes, there is some evidence of some protection of HPV vaccination, especially in women who have HIV and have been found to have some high-risk subtypes of HPV. Currently, we are finalizing that clinical trial where we are vaccinating women with Gardasil 9 at the Uganda Cancer Institute and so other sites Africa, about 4, one in Stellenbosch, one. So it's hopeful so far that it may benefit women who are HIV positive and who already test HPV positive to prevent the virus causing, CIN lesions to progress. Yeah,
Thanks,
and I
Nick.
was reading
This
some
is really
articles on it that I
about
can't pull
immediate-
them out now, that it is already being rolled out in other developed countries for HIV positive men because they are at high risk of this.
And
type of
just to be
cancer.
clear on this, is this
Yeah.
outcome then the immediate clearance of the HPV? Or is it about reinfection,
No, it prevents the development to
of
cancer
lesion?
lesions. Yes. And of course, that will be preventive, isn't it?
Yeah. No, I understand. I just want to compare the different end goals, the outcomes, whether it's like
the end goal was prevention
development
of
of
the lesions.
immunity or reinfection, preventing reinfection, especially because you can have no virus now, but then you get it 1 year later, or the end goal, which is no development, no cancer development. But
No
it's
cancer
good, and maybe
development.
you can share some of these if they are there. I know there's been a study from India where they've done a lot of these long follow-ups, but I wanted to know if we have others from Cameroon.
Yeah, we have others, especially this one is a multi-site clinical trial funded by AIDS Malignancy Consortium US. So I may not present the results of one site, but I know very soon because we are ending recruiting next month.
Thanks.
Yeah, but already we identified with PIAS, that already some countries are already taking it up.
Thank you, Annette. Maybe we can get Dr. Manga or Dr. Sibomana to weigh in on that before we get back to Benda.
Yeah, not really anything to weigh it. I was just interested with the response from Annette from Uganda. This trial, what is the age limit? You say you are taking adults from up to which age? That's just what I want.
25 years and above who are HIV positive and already adhering well on their ART for at least the last 6 months, and who test HPV positive for HPV 16, 18, and up to 45, and P3, the high risk types.
Okay, great. That's very interesting. Thank you for sharing.
Yeah, very soon we should have a stronger head from Africa, Sub-Saharan Africa as well.
Thank you. Benda, you had something to add to the debate on age. Kindly your comments.
Certainly. So I have posted on the chat what the WHO recommendation is on single dose, 2-dose administration of the HPV vaccine. But I've also posted what the WHO SAGE recommended in 2022 about the different ages and the cohorts that can be administered for the vaccine. It's quite a detailed technical document, but if someone reads through it, they can be able to also be guided on advocacy. Thank you.
Thank you, Benda. We had another question from Caroline Okere. Do you mind just unmuting and asking a question?
Hello.
Yes, we can hear you.
You can hear me?
Yes.
My name is Caroline Okere from Kenya, a member of Kilele Health. My question is, okay, sorry, I joined in a little bit late, but I heard about the vaccine, boys being vaccinated. I would want to know from what age are the boys being vaccinated? Thank you. Back to you, Sydney. Back to you, Sydney.
Simon, maybe you can start.
Yes, I think the question came in earlier. I already mentioned it that it's the same age group. The age of the boys is not different from that of the girls. Maybe Benda has studied the age document from WHO very well. Maybe you can throw some light on that. I don't know.
Maybe if I can add this, and this is for everybody on the call who is practicing advocacy, like Caroline in Kenya. you need to be guided by the government regulations on vaccinations in your country specific, because WHO recommends 9 to 14 to 14 years. But in Kenya, for example, it's 10 years to 14 years for girls and not boys. And so if you want access to the vaccine and to advise communities about it, you would need to advise them to go to the private sector to access this vaccine. And so I would say it's good for us to also familiarize with the government policies in country. Different countries in Africa have different regulations for HPV vaccination, and even the ages 15 and above are not covered in some of the government-supported vaccination programs. Thank you.
Can I supplement on this? Because I think this, in terms of giving out information, in terms of sensitization, this is an important issue. Because I think when people hear these public health brackets that are recommended based on, for example, availability of resources, sometimes people associate it with safety. And I think this is a question that was asked earlier on, was if you say, oh, we're not vaccinating boys, then people think, okay, so is it not safe for boys? How can it be not for boys and it is safe for girls? So then they just don't take it up. Or if you are vaccinating only young girls, is there some sinister reason why you're vaccinating young girls? And yet the decision is not made because of safety. The decision is made because of availability. And therefore, if a person would want to get it and they are 30 years, they can actually get it. But of course, it might not protect them because they are already protected by exposure. So I think some of these nuances are important to explain to, especially to people who are doing awareness and community mobilization, to say, why are we targeting this group? It is more of a health benefit analysis as opposed to a safety benefit. And I don't know if this is usually communicated, but I see very easily why people might have questions to say, oh, why are you not only vaccinating girls this age? You are targeting people who have not yet started childbearing, and therefore, why are you not vaccinating the other group? I don't know if this should be put out there as the details of the decision-making process that goes beyond safety, but considers where do we get maximum value.
Maybe, Sydney, if I can respond to that to John Black, and we have a lot of rain going on in Nairobi right now, so I'll shout. If I can respond to John Black, I agree that as advocacy agencies, we need to equip our organizations and health advocates with credible information and standardized, so that when they go to the community, they are able to speak authoritatively about, one, the need for the vaccine, two, the vaccine dosage and the adherence to the vaccine dosage based on the policy, but at the same time to create an understanding so that we as the community agents can go back and sensitize the communities for uptake. Secondly, we also need to empower patients' organizations to sit on technical working groups that inform policy, so that they can also be able to meaningfully engage and inform decisions that bring back feedback from the community. And so it's about all of us, the scientific community, working together to ensure that we are formulating policies that serve Africa. Thanks.
Thank you very much for that, Benda. We have time for about 2, maybe 3 at the most questions. I'm going to give Annette the floor. Your hand is up.
Sorry, I just forgot the hand up. Sorry.
No problem, no problem. 1 or 2 other questions. We are hearing all the issues. Maybe Dr. Manga, you can explain. One question I had was this issue of medicines expiring in the supply chain. How did you deal with that issue? How did you overcome that? Because it's not something that is isolated just to Cameroon.
Yeah, in 2019, when I said 50,000 doses of Savarix expired, the vaccines were not yet in Cameroon. They were stored somewhere in Europe. And then when we needed them, we were supposed to collect. And since the people were not taking the vaccine, there was no need for us paying additional resources to bring the vaccines to Cameroon. So we allowed them there until they got expired. And we're going to be destroyed and a destruction certificate made. So that happened where they were stored. But in Cameroon, where vaccines are currently expiring, that is with the ministry, with the EPI program. So I have no idea how they manage the expired vaccines.
Thank you very much for that. I think that's a problem that cuts across almost all of sub-Saharan Africa. Eunice Wambua, you had a question. Kindly unmute yourself and ask.
Hi, everyone. I still wanted to inquire to know if you've already been exposed to the virus. Can you still get the vaccine and will it be safe for you?
I think let me just respond to that very fast. I think one medical oncologist that spoke a few minutes ago actually addressed that issue. He said that the vaccine does not change the course of HPV. So if you are already infected with HPV and you receive the vaccine, it doesn't harm you. It will not make the HPV worse. In fact, it will do nothing. The only thing is that it's not going to protect you. So it's a waste of resources. Thank you.
Dr. Manga.
Maybe, Sydney, that's a debate I usually have with other technical experts. We do know that the HPV vaccine also protects against other cancers, and especially if, for example, for immunocompromised women, if that vaccine was to be administered, and I'm saying this just for us to be aware, maybe it would also help with other preventative measures for other cancers or other HPV-related infections, like warts, for example. So I don't know, Dr. Manga, if we were to be open about it, in other countries, they're doing it because they know the preventative measures for women in developed countries. Maybe when we get to that level where we're able to meet the demand, the need for HPV vaccination for cervical cancer prevention, we should also be thinking about our women in the future around that. Thank you.
I agree with you, Benda. It doesn't, so the message is it does not hurt you. Okay, so it could potentially help, but it definitely doesn't hurt you. So I think the message is, we should sort of carry out of this is it doesn't hurt you to get the vaccine. Resources is a different question, but it doesn't hurt the individual. And I agree that there are certainly other HPV related cancers. And sometimes, you know, a patient might have one strain, but does not have the other strains of HPV, which might be in the vaccine. So it's a much more complicated, nuanced decision about what benefit the actual patient will get, but it's not harmful.
What I'm picking up from both of you is resources versus availability versus efficacy. So those are all different issues and it just shows you how many different aspects there are to making that decision on who you should vaccinate, what age they should be, and at the other end, you know, building trust in the community so that by the time you're going down there, they're already sensitized. So these are the debates we still need to keep having as we plan ahead. We might not have the resources right now, but in the future, opening up to boys, opening up to, you know, other high-risk individuals would be something to be considered. We are almost out of time. I don't see any other questions. If anybody has a burning question or something they feel they wanted guidance on or a response from one of our speakers, now is your chance. Mary Mwangi, I see you again.
Yeah, thank you. Mary Mwangi here from Kenya. My question is, I don't know whether it's Dr. Simon or who mentioned that people living with HIV, they also get vaccinated. So my question is, does it not interfere with the HIV treatment? Since even those people with HIV who get cancer, sometimes they are not given chemotherapy because of interfering with HIV treatment.
Anyone wants to tackle that question? I believe there's a lady from Uganda doing a study. I forget your name.
Yes, it was Annette from Uganda who talked about that study.
Sorry, I didn't get the question. I was distracted.
Oh, sorry. The question is, I'm asking, you mentioned about people living with HIV that they can also get the vaccine. And sometimes even those people with HIV, they don't get chemotherapy because it interferes with the treatment, HIV treatment. So my question is, this vaccination, is it not the same? Can it interfere with the HIV treatment, or it is on trial? Or what
No.
is your thought on that?
No, actually, that's not the right information. It's all known with treating HIV-associated malignancies and cancers. One of the reasons that some of those cancers come is poor adherence to ART. So we really strongly encourage, adherence to ART in addition to chemotherapy. Cancer drugs don't stop you. They are not contradicted with ART. That's not true. And the same applies to the vaccine. Actually, currently, for them to enroll in the current clinical trial of the HPV vaccine, they must demonstrate good adherence to ART for at least the last 6 months.
Thank you, Annette. Does anyone else want to weigh in on that one?
I agree with Annette's comments. I'll say the question about chemotherapy is a little bit more nuanced. People should still get treatment. There are different types of chemotherapy that impacts the immune system in a lot of different ways. So sometimes medications might need to be adjusted if there's overlapping toxicity with HIV medications. But the main point is the HIV should still be treated and the cancer should still be treated. And many times there's a way to do both.
Thank you so much for that. Some eye-opening discussions. I just want to say that, sorry, we are out of time, but does not mean that this discussion should stop here. We will be having, further discussions on different issues, and we will be sharing the recordings, and we will have other forums whereby people can be able to weigh in and ask their questions and also give suggestions for different topics to be discussed. At this juncture, number one, I just want to thank our speakers, Dr. Simon Manga, for telling us about your experience in Cameroon, and Dr. Hassan Sibomana from Kigali, Rwanda. We appreciate you taking the time to come and educate us. I also want to thank everybody who has joined us today, because without you, this forum would not be possible. Without you there to ask your questions and discuss, without that desire to learn and to share experiences, then this would not be happening. I want to sign off right now and say thank you from my end. And I also want to give a chance to somebody from the Echo Hub, Mr. Charles Muya, who is the Africa Echo Hub coordinator. He's the one who has been sending a lot of emails, running the slides, dealing with the technical issues. So Charles, maybe you have some announcements or something you want to say before we close?
So thank you very much, Sydney, and indeed, thank you so much to our speakers and our participants for joining us and actively participating in the session. So we are happy that you're able to successfully onboard and join through the new IECO platform. So as Sydney mentioned, we are going to share the recording, and we are still going to continue using Basecamp. But as time moves on, we are going to maybe fully switch to IECO as we move along. So our next session will be held on October 19th, and we will be sharing the focus of the session in the coming weeks. And we will update IECO with that information, and also share the agenda on Basecamp. Otherwise, we are very grateful that you are able to join, and we wish you a good time. Thank you so much.
Thank you so much, Charles. You do a lot in the background to make sure that these things run smoothly. Also for the steering committee, ECHO steering committee, who is responsible for coming up with the topics, reaching out to speakers and making sure that everything runs seamlessly for the next year, 2023-2024 ECHO Hub. We also thank you for your efforts. Again, my name is Sydney Chahonyo, and it's been a pleasure hosting all of you. Have a good evening, and we'll see you at the next ECHO. Goodbye, everyone.
Thank you, Sydney. Bye.